To start off with talking about radiation therapy technology, outside of our linear accelerator, we also have our imaging machines. So, depending on your size of your facility and what they use, you may have multiple or you may have just one imaging machine. And the most common is going to be a CT, which stands for computed tomography. We do see some nowadays that could have an MRI machine as their kind of simulation or pre planning software and imaging process. But for most standard, it's going to be our CTs. So we do have our machine over here. So this is what we call a gantry, the big donut. That's where the patient is going to pass through as the imaging occurs. So the patient will be on the table and it will slide in and out depending on where we're scanning. We'll have a control console right here, depending on the brand. So if you have like GE, if you have Siemens, Philips, Samsung, whatever you have, they are going to present a different software. So it's kind of like when you have an Android versus an Apple phone. They can do very similar things. It just looks a little bit different. So that goes for your console as well. So this here is going to be a Siemens machine. And so they're planning out their imaging, and you can see 3 different body planes right here. We're only going to image what is necessary for the doctor to create their treatment plan. So we'll scan through all of that, and we'll do any kind of changes that might need to occur. But then we will send those images on to the doctor. And then over here on the right-hand side, this is showing you in our imaging machine. Again, this is still our gantry, our donut hole for the patient on the table to pass through. This patient is likely being treated for a head and neck cancer. And so with this, we have a thermoplastic mask on top of them. And so that conforms to the shape of their head, their neck, and their shoulders to help keep them immobilized. Within all of our imaging rooms for RCT or MRI, we have to have some type of laser accuracy. So we have a laser off to the right-hand side. We're going to have one off on the other side of the patient. And then we have one that's going to shine on top of the patient. And so we can find our crosshairs where those 2 lasers overline. We can find those little components to help us identify where we need to line up the next time. So here we have our main machine, which is the linear accelerator. So on the schematic drawing here, we have what's called our drive stand that's in red. And so this is kind of the back of the machine that doesn't move. It's going to house more of our electrical components and the things that help power our x-ray tube. In the green, we're going to have our gantry. It is that whole component that's circled because that's what rotates. But when I'm talking about the gantry, I'm usually referring more to the treatment head because that's where our x-ray tube is and that's where our actual treatment beam will come out of. So then next we've got our KV imaging system in that purple color. So this right here, the one I'm highlighting, is our x-ray tube, and then situated opposite of it is our detector. And these will extend out. So they're folded in right now, but they'll extend out so they're reaching on either side of the patient so we can take our KV images. So that can be just a generic x-ray as AP or lat or an oblique, or we can do what's called a cone beam CT, CBCT. And so that's going to allow us to visualize the tumor and the surrounding tissues and make sure we're aligned the way we should be. And then we're going to see that we have our treatment couch. See that right here. So that couch is going to be where our patient lays on the table. It can move up, down, in, or out, side to side. There's a lot of capabilities with it. Also on the back side, you can kind of see it hanging here. We have what's called a pendant. And so that's a remote that allows us to control the table as well as the whole gantry. And then at the very bottom of our linear accelerator in the blue, we have what's called a portal imager. So this is an additional detector that's folded in right now, but it will extend out so that it's underneath the patient. And that is situated opposite of our gantry head. And so that would be MV. So I'm going to put it in blue right here. So mega voltage is what it's using. And it can produce x-rays just like the KV system can. They just won't be as pretty as what our KV images look like. And then lastly, over here on the right-hand side, without any kind of drawing over the top, we have our linear accelerator. This is a newer version in the Varian manufacturer. So it's called a TrueBeam, and it's one of the machines that I learned on. And I really personally like Varian, the manufacturer. I think everything that they have is very easy to use. I think everybody has their own preference. It's kind of like when you go through CT or anything like that, when you see that there's GE out there, there's Samsung, there's Philips, there's Siemens. You kind of just figure out what you like. But Varian is a strong manufacturer within radiation therapy. So you can see that they have the table. We're able to see the different buttons on where it would be located down here, kind of in this little alcove. We have the pendant that's on the back. Our table is actually extended out further, like we would be actually treating the patient. We have our gantry head, and then we have on this side the x-ray for the KV system, and this would be the detector for the KV system. This would be the MV imaging arm for that MV system. And then one thing to notice with this one is, do you see this circle here? It looks more like an oval at this point. So this circle, it's present on my other image as well. It's actually a rotational basis for the couch. So this couch is actually at a 90 degrees to my gantry right now. We can move it to an oblique angle. We can move it so it's straight on. We can move it a variety of ways. And that's all dependent upon where the tumor is at, how we can reach it with different angles, and what the physician wants to do. Our linear accelerator imaging is located on this slide. So we can either take MV, which is megavolt imaging, or we can take KV, which is kilovolt imaging. If we're doing MV, we typically call them port films, because it's kind of like a bird's eye portal view. And then if we do just regular KV, that's just a generic X-ray. But then if we do CBCT, that's using the KV arms, but they're rotating around the patient. So with this patient here on the table, we can see the MV beam is giving us an AP image, and then our KV would be shooting across and giving us a lateral image, which is true because I can see these in these little images right to the left of the picture. So the MV image that's labeled here, what they're looking at is actually a prostate patient. And so they're looking for the fiducial markers. Sometimes you will place these in order to help us locate exactly where we need to be. So if you have a stationary landmark within the tissues, you're able to constantly image and realign to where those are located. So this would be our AP image. And then this is our lat, and I can tell because I can see part of the pelvis and where the hips line up. So here still is where we're seeing those fiducial markers. And so we're able to align from the very first day until now. So over here, you can see where those fiducial markers, the green surrounding it, is where we had them placed before. So we're trying to make sure when we flip back and forth that they are aligned correctly. Up here, if we are looking at a spine or a lung patient, based on where it's centered, I'm assuming it's a spine patient. And so when we're imaging with these, we have an AP KV image. We have a lat KV image. So these ones look very similar to what x-rays would. It's just not quite the quality that we would expect from diagnostic imaging. And then we have underneath that an AP MV image and a lateral MV image. So megavolts obviously is going to penetrate much deeper, and it's going to end up with more overall exposure to the image receptor. And so when I say that, the images are going to be a little bit overshadowed by some of the anatomy. So like here, what I mean is we can't see the skeletal markings amazing. You can see the lung field pretty good, and you can see some of the mediastinum and where the heart and everything would be. And then we realign on the lateral, we can see, again, it's just not as pretty. There's not as many landmarks to align to. So MV is an option, but in my opinion, KV is just prettier, easier for us to do our job. And then down at the bottom, we're going to see between A and C images that this is what we call a cone beam CT or a CB CT. And so with this, where they are imaging at is this structure down here. And so when they take their imaging, they're going to align it back to the very, very first image that they took. So from my knowledge, CBCTs again don't look quite as pretty because they're KV images that are taken very quickly. They don't use as much dose because we're imaging them every day. So we don't want to use a high dose like we would in a normal CT. So C, this image is more likely to be our actual CBCT. It's not going to look as pretty. There's more artifacts that are splattering throughout versus A looks a little prettier. So that might have been more of our simulation photo that we got from the first try. But anyway, we're going to flip back and forth from this day that we just imaged back to their very first day from simulation, and we'll flip flop those images back and forth until we can align them so that they are almost perfectly overlapped. So here we have a schematic of how our drive stand and the gantry all come together and all the components inside that are important to us. So first off, in this red rectangle, we have what's called the modulator, and it's going to supply our pulsed power, so our electrical current that comes in, and it's going to go to the klystron, which also may be referred to as your magnetron. And so when it supplies it there, that klystron is going to produce high energy waves. So they're going to be megavolt waves. And so that's going to be what helps accelerate our electrons. So then going back to the modulator, it's also going to supply its pulse power up to the electron gun. So the electron gun is going to allow for the electrons to boil off, just like we would in generic X-ray in the X-ray tube at the cathode. We're going to boil off enough electrons, and it's going to push them forward into what we call our accelerating waveguide. So those megavolt waves that came from the klystron, they're going to come up through this yellow waveguide, and then the electrons come through this accelerating kind of funky shaped waveguide. And it's going to be surrounded by some structures that help push it forward. So that's kind of why it looks funny. But when we apply the megavolts to those electrons, it really, really is going to increase their energy really, really strong. Another thing to say before we move too far forward is this green rectangle is what we call our circulator. So its job is just to make sure that the megavolts that are coming from our klystron don't go back. So it's pushing them forward into that accelerating waveguide for the electrons. If those accidentally came backwards, we could say that there could be damage to our klystron, or also known as the magnetron. So circulator just keeps it moving forward, just kind of like Dory in Finding Nemo, is just keep swimming, just keep swimming. The circulator keeps them flowing forward. So after those electrons have been accelerated through the waveguide and had interacted with the megavolt waves, it's going to go to what we call our bending magnet. So the bending magnet's job is going to be to take those electrons and redirect them down into the treatment head. So as you can see, this is all going forward, right? If we didn't bend it and push it down towards the patient, then they would just continue out the front way, and that's not helpful to us. Our patients aren't standing up on top of the table. So it's going to go through this bending magnet, which is going to allow for them to spin around and then end up going perpendicular to what they were. So they're going to go straight down, and then it's going to interact, and we have a target that's within there, just like we would with X-ray. We have our target, and so when it interacts, it will create the photons that are megavolt electrons turned into megavolt photons. So that will interact with the patient, causing the treatment to occur. So here's a breakdown of everything that I just said. So our modulator is going to supply power to our klystron, and it's going to allow for the klystron to then produce high energy waves in the megavolts. It also will supply energy up to the electron gun, where those electrons will be boiled off and then pushed forward. The circulator is on the klystron side, and it's going to prevent any backflow of those waves from getting to the klystron and hurting it. A lot of times we will have like a water cooling system that helps prevent the magnetron and the modulator from getting too hot. So then that's kind of more within the back side of this drive stand where it doesn't really move. But then within the gantry, we are going to see that after the electron gun produces those electrons, The accelerating guide is in the gantry, and it's going to transport it, and it adds the megavolt wave energy, and then it will be bent at the bending magnet to be directed down towards the patient. And then inside of the gantry head, we're going to have our target that's placed in the path of the electrons. So when it interacts, our megavolt electrons are going to then become megavolt photons. And then a little bit further into the gantry head, so the actual location of where our bending magnet is, and then what it will interact with. Um, the photons are going to be shaped by the primary collimator. So we do have a primary collimator, which is going to be kind of right at the top, after we have bent the electrons to go back directed towards the patient. So we have a primary collimator that helps limit it to a field size. So kind of like an X-ray when you use a 10 by 12 or a 14 by 17, we're just limiting it to the size that we could possibly treat. Then we're going to have a beam flattening filter that's located within here. And so the flattening filter is right here. Again, kind of like right underneath where the bending occurs. And its job with a scattering foil is going to be to make it a more uniform beam. So we're trying to get rid of any really, really high energy photon or electrons, and then any really, really low energy electrons. So that way the beam, when it's produced, the photons are similar energy. And then we're going to have dual ionization chambers that are going to be right below there that will interact with those electrons. And it's going to detect the symmetry and the dose rate that's coming through there. And if something's off with this, it'll actually throw a flag, like an error on our screen. So that way we know that something's going wrong inside of there. Typically, that's just to make sure that everything's kosher, though. And then we're going to have our field defining light. And so with that light, we're going to be able to see just truly how large our field size is, and then anything else that we need to adjust for. So with X-ray, remember, we only usually have like a square or a rectangle. But within radiation therapy, we have what are called multi-leaf collimators, also known as MLCs, multi-leaf collimators. And so they move in and out, and they can shape to any shape that we want to make. And so our secondary collimators, which are also referred to as our MLCs, are going to take, let's say, the 10 by 12 and cone it down even more to be the shape of an avocado, whatever you want to shape it to, depending on what the tumor shape and size is. So we will change that with the MLCs, and that's the very, very last thing that it's going to go through before it will come out of the gantry head. So just like with X-ray, where we might have different kVps set for different protocols. So let's say for a chest, we might be doing 120 kVp versus like a hand could be 55 or 60 kVp. The same thing is kind of true within radiation therapy in the sense that we have different energies that we utilize, but we don't pick these as therapists. This is already built into the treatment plan that was developed by the dosimetrist and the doctor. So we don't mess with this. We just ensure that the quality assurance has been ran on these beams and that everything is functioning correctly. And so we typically have anywhere from 4 megavolts to up to 35 megavolts. And the different volts have different depths where they deliver the majority of their dose. So you still have some that are going to penetrate further into the body, but that kind of just have done research on where does most of the dose end up with these different beams. So 4 megavolt is approximately 1 centimeter below the surface. 6 megavolts is approximately 1.5 centimeter below the surface. 10 MV is going to be 2.5 centimeters, and then 20 MV is around 3.5 centimeters. If we were to talk about that a little bit more in depth, we call that our percentage depth dose. And so you can see as we look at the different beams over here, the different colors represent the different beams, and then the percent depth dose is saying how much of its dose is delivered at what depth. And so the depth is written truly down here. So if we're looking at just getting further into a depth, and this is in millimeters. So as we're getting up to like 3.5 was what we said was kind of our highest at the moment, right? So if we're at like 3.5 centimeters, which would be around 35 of our millimeters, when we're looking at that, you come up here, we're seeing 100%, which is what we want, is found on the blue line. And so that represents our 20 megavolts. Okay, you can do the same thing with the 4, the 6, and the 10. It's just where the majority of its dose is delivered at what depth. And so that helps us because we want to get as much of the dose to the tumor, which could be very, very close to the surface, or it could be very deep inside the patient. And that also determines what angle am I going to come in at? Because if I'm trying to treat a tumor that's close to the spine, but they're laying on their back, am I trying to treat from the front, where I'm going to have to use a lot more dose and have to use a higher MV to treat very deep? Or do I turn my gantry underneath the patient and then I'm much closer to where that structure is? Just like our photons, so the megavolts, we have electron beams. And so electrons are typically used for much more superficial structures because it's going to deliver it much closer to the surface. And so we typically have a higher surface dose, and then it's a rapid fall off when we compare it to photons, because photons, a lot of them are still going to penetrate pretty deep, but the majority of the dose was just at a certain depth. So with our electron beams, we have anywhere from 4 MeV up to about 22 MeV. And so on this chart, it's very similar to what we talked about last time. Is that we're going to see a very, very high dose at the surface level. So we're saying we're getting a lot of dose within, let's just do the 6 MeV, which is the purple. So we're saying that 1 to 1.5 centimeters is where we're going to see our highest dose. But then do you see how fast it just drops down? So anything after that is really not getting much at all. And so all things considered, this is going to work better for our superficial tumors or more like skin cancers, is what we use electrons for. If you go back to the photon depth, the photon really extends out because there's still quite a bit further into the body. It's not as much as a rapid fall off as the electrons are. Quality assurance is a huge thing in radiation therapy. And so we have some tasks that we have to do every day that we are going to be utilizing our linear accelerator or our imaging systems. So our quality assurance for simulators, meaning that's going to be our CT machine or MRI if you have that specialized version. We have to check our lasers every day. We have to check our distance indicators, gantry lasers, and then our CT number accuracy. So on this image here, they have a phantom on the table that they're going to scan. One of the very first things they can do is they can line up their lasers and see how far off they are. So we have a leniency with our lasers to be off by 2 millimeters. So there's typically going to be a pretty good like line or indication if things are off, and you have to like measure it and decide how far off from the crosshairs you are. So they have lined up to this crosshair here on this side, up on this side, and then they'll measure on the opposite side as well. And then they'll use a measuring device to see, okay, is it directly on my crosshairs that's on the phantom, or is it slightly off? Another thing is your distance indicators. So when we measure from one distance to the next, we'll use our CT machine to tell us what it thinks it is. And usually it's pretty dang close. And so when we line those up and we move the table in, we're going to see on the device, okay, I moved 5 centimeters on my phantom device. But then we're going to see what the CT system said. Did they actually move 5 centimeters, or does it say that I only moved 3 or I moved 6 or whatever it is? But with our distance, we can only be off by 2 millimeters. Our gantry lasers. So just like we had the lasers on the outside, when we push the table inside of the gantry, inside the donut hole, so the donut hole's right over here, we haven't pushed in the table yet, but when we get inside the gantry, we're also going to have those same lasers, but they're coming out from this black part from the laser. So we'll line those up again and make sure that it's also not off by more than 2 millimeters. And then we have our CT number accuracy. So on this phantom here, sometimes people have another phantom that they'll do this with. But right here in this center block, you can see all these little circles. And so they are filled with different density of materials. And so when we scan our imaging, we're going to scan and we're going to look at the numbers of the different densities and compare them to what they should be. So we'll evaluate all of that, and it can be off by 0 to 5 Hounsfield units. So then moving into our quality assurance for the linear accelerator, we do have other things we have to evaluate here. So our door interlock, we have to make sure that's functional. So that means that when I hit the button, it actually shuts, and also that my monitor or system knows that it's shut and it says that it's locked. If it doesn't lock for some reason, or if your machine starts to let you expose before your door is locked, that's a problem. So you have to get that fixed. Your audio visual monitors, so how you see the patient and you hear them, they have to be functional. You can operate with only one working, but if both go down, you're not allowed to treat patients. So you need to get the second one fixed very quickly, but you at least have to have one in order to treat patients that day. Our lasers, just like we did with our CT machine, this is more of a complex phantom that's on the table right now. Usually the physicists use this, but there's going to be crosshairs on either side that we can align to and ensure that it's within there. Otherwise, the one that we use the most frequently is going to be this daily QA phantom up here that's all flat. It just lays flat on the table and you just plug it in. It's so easy. But again, you're going to line up your lasers and ensure that you're not off by more than 2 millimeters. It'll have a measurement device on there. And then on the same plate, what you're going to do is you're going to raise up the table and you're going to turn on your distance indicator. So that's telling you how far from the inside of the gantry head to the patient's skin. So it should give you like a marker on the patient. It'll tell you all of your centimeters from how far off you are. And then whatever number you get, you're going to compare with an actual ruler. You're going to measure. And so you're going to see how far off you are, and you can be off by 2 millimeters and it's acceptable. Then we have our beam output consistency. So same thing with this daily QA. We're going to line everything up, and then we're going to run our individual beams. So if we have a 4 MV beam, 6 MV, 8, 10, 12, 20, 35, whatever ones we have to run every single one of them. And so it's going to run it a few different times. And so when it runs it for each individual beam, it's going to compare the consistencies between them, and they can be off up to 3%. We'd really like it to be much lower than that, just to say that the output is what you're truly getting. Because if I'm saying, oh, I'm going to treat my patient with 20 MV, but then when I go to do it, it's actually giving more like 6 MV, that's not helpful to the patient's tumor. So trying to have that consistency is important. Then we have our electron output consistency. So we'll do the same thing we just did for the beams, but we're going to do them with the electron beams. So that's going to be MEV. And so we'll run all through all of those multiple times, and then we'll compare them, and it'll give us our percentage. What's really nice about like this daily QA is you can also get the software with it that tracks everything. So it'll go to like a separate computer, just a regular like Dell laptop or something. And when you have that set up, it's going to show you exactly on this graph, and it stores the information too. So you have record of all your quality assurance. It's going to show you for every single beam on every single day that you ran it, what was the output, and it's going to measure that it's consistent. If it's past that 3%, you're going to down here, you're going to get something that says failed, and you're going to have to run it again or have the physicist come take a look. But if you passed, that means good. You're in the green, you passed it, it's within that 3%, you're good to treat for that day. Our room setup is going to be dependent upon where you work. So everything may be a little bit more condensed, or you may have a larger space, but regardless, you are going to have your gantry. So we have our gantry back here and our imaging arms that come out. We're going to have our table, or sometimes referred to as couch in radiation therapy. We're going to have the capability of moving our couch all which directions. And obviously it's not going to let it hit the gantry, but it can go pretty close to the gantry. We're going to have a setup monitor that's hanging from the ceiling usually. And so it's going to tell you when you pull up your patient on your console back in your control space. Up here, it's going to show you exactly where the table's at and then where it should be for when you're lining up. So you're going to try and get up there as close as you can, and then you'll make your fine shifts based on where your marks are on the patient's body, and then also motion management. You're going to have cameras or audio visual, so you can hear and see from up there. That's going to go onto your console as well, so you can see the patient and hear them while you're treating. We're going to have immobilization storage somewhere, so that could be usually, you can either have like a clothing rack that you hang them from, or you could have different cabinets where you put them inside. We're going to have some type of changing location. Some places have like an actual changing room or multiple changing rooms so they can get patients prepared like before they go back for their actual treatment for the day. And then a therapist control area. So that's where we're going to be the majority of the time and operating all of that. So again, our gantry is going to house our x-ray tube and the whole process within there. We're going to have our imaging arms that come out. So this is a good representation of when those imaging arms are out. This is the KV x-ray tube, and this is the KV detector. We have our MV gantry head, and then we have our portal imager that comes out down here. We have our distance indicator. So remember when I was saying that it was going to put a measurement down on the patient's skin? This is also for quality control, but it's a ruler that it shines down and tells you all of your centimeters as you go down. And then you're going to look for the centimeter that goes across your crosshairs to see how far of a distance you are from the gantry head. Then also has the capabilities of rotating 180 degrees either way. So a total of 360, but it can't continue past that 360. So if I start down here, I can rotate all the way up and around and then back around on this side. But then it won't let me go any further. I'm going to have to stop and then come all the way back around the other direction. Otherwise, it would pull out all of the electrical cables. Our table or couch has quite a few options for maneuvering so that we can center correctly. So typically we start out just with the table just straight on with the gantry, and it's going to be the lowest setting so we can get the patient on the table. Then once they're on the table, we'll raise them up and start bringing them in towards the gantry. So our movements allowable are going to be up and down. We can go in and out, so towards the gantry or back away from the gantry. We can go just slide the whole table left or right. We also can tilt the patient. So we can kind of tilt them more to the left or the right, meaning that their right side's higher than their left side or their left side is higher than their right. We can also rotate the whole table. So all of these degree markers on the floor for the table, you can see it's at 0 degrees here, but then we can rotate the table so it'd be at 20, or we can rotate the table so it'd be at 40, at 60, or at 80. Some tables go even further than that, but it allows us access to different angles that maybe we couldn't do before. And then we also have what's called pitch. And so pitch is going to be how high or low the head or feet are. So we can actually lower the head on the table, or we can actually raise the head on the table. It moves all flat. So if you move the head up, part of the body also moves up too, but it's going to be at an angle. So we can kind of manipulate that. We also have what's called a pendant. So that hangs at the end of the table usually. And that pendant, we're going to be able to move the table up and down, in and out. And then we can also rotate the gantry. So if you wanted to know exactly what each individual button does, it's labeled on this image here. We also can control our lasers in the room. We can turn the entire room lights off just with hitting this button up here so we can see better. We can control our multi-leaf collimators to go ahead and set them up so we can see as it's projecting down onto the patient's skin. We can control the speed of the gantry, how fast we want it to be when we're moving things around. There's just a lot of movements with the table and the gantry that we can do with that pendant. So if you don't want to have to hold the buttons on the side of the table and stay right there, you can instead grab the pendant and you can walk a little bit further. I think that there's like a, I don't know, 3 or 4 foot allowance with the cord that attaches to the pendant, maybe more if you stretch it, but that's about how far you could step away from things to move whatever you need to. As I mentioned, we do have what's called a setup monitor. That's typically hanging from the ceiling. So we have a couple monitors here. Whenever we bring up the patient, it's going to be very specific to their information. So that's why it's really important that you have the correct patient pulled up. Because if you go in the room and you still have your previous patient pulled up, the information is going to be wrong and you're going to set them up wrong. So we're going to have the shifts that are needed to get to the location we need. So there's going to be, like over here down in this bottom picture, it's going to tell you what your actual location is and where you're at. And then it's going to tell you where you need to be. So this yellow or orange color that we get is not a good thing. It usually tells us, okay, we're missing out on something. I need to move. I'm in the wrong spot. So we will have to move to that location in order for us to be able to truly start imaging, because otherwise we know we're going to be off if that is not a good color. So if it's just plain no color, that means we're golden. We're in the good spot. So when it says something like vert, that means that we need to raise the table up. If we are talking about longitudinal, it's going towards the head or the feet. And then we have lateral, which is from left to right. And so, one thing that was challenging for me as a student with rad therapy is trying to remember which direction is which. Because when your number comes up positive for lateral, it means you're going for one direction. And I believe our system, it was set up if you're going to the right, it was positive. But then if you were going to the left, it was negative, which doesn't seem like it should be a challenging thing. But when you're trying to do the mental math of, oh, I am at 1.25 on the right side, I'm positive, but I actually need to shift 3 centimeters to the left. You're kind of like doing mental math and having to subtract it and figure out where you are. So that definitely took a little bit more for me because I'm not the best at mental math. I'm more of a, if you ask me to write out, a hard equation, I can solve it very easily. But trying to think about it in my brain and do the numbers right there was more challenging for me. But something that you definitely learn when you're in the clinical setting and as you are a therapist. Another thing is that if there's any kind of setup notes, we can see those on the left side of the screen. It's usually kind of just blank unless they have specific setup instructions, like check photos if we do something kind of strange with the patient, or we'll say that they have a uh, vac lock, they need to have their toes with a strap together. We'll say if they need a diving ring to help hold their hands together, if they have a bite block when they are doing mouth or esophageal cancers, if they have a mask, we'll put that on there. And then if the dosimetrist decides that we need to shift a little bit different locations, they will put that in the setup notes too. So we can see all that on the screen while we have the patient on the table, and we can match to what we need to make sure they're in the correct location. Here we have what's called motion management. And so that is going to be us evaluating the skin of the patient and their different motions. So the biggest one we usually focus on is going to be breathing, because we can't tell somebody to completely stop breathing for the entire treatment. We can have them hold their breath in certain circumstances, but they can only do that for so long. So, one thing that we do is we can do motion management where we monitor the skin and as they're breathing, and it will actually turn off the beam if we're trying to treat and they take a breath during the middle of it. I think that'd be awesome for x-ray, because I can't tell you the number of times I've been doing a chest x-ray and somebody starts to talk during the middle of it, or you know is letting out their breath before they're supposed to. So but with this, we are using a red infrared light over here, and we will turn off the rest of the room lights and we'll shine that on the patient's skin, and then it's going to monitor from there. And this is the screen that will show that. So it'll say, like, this patient we're treating somewhere on their left side. It could be a lung cancer patient or it could be a breast. It looks like left breast, actually. It's labeled up here. And so with that left breast, we are concerned about the heart and the different areas that we are treating that are close to said breast. And so it will monitor and it will tell us our vertical, so up and down, our longitudinal, which is in and out of the gantry, lateral, left and right. We don't really use mag that much. Um, if we've got rotation, so if our head or feet are more positioned to the left or the right, comparatively to each other. And then we've got roll. So if you are rolling up on your side, if the left or the right side is higher. And then our pitch is if our head or our feet are higher or lower compared to each other. So this green means everything's great. They are within tolerance, they are not moving. And so then we have these kind of like little shadow of lines. I don't know if you can see those that just go vertical. I don't want to draw right over the top because then you can't see them. But those are our thresholds. So if that green gets all the way to the outside, like right here, if it goes past that threshold, it is immediately going to turn red and it will shut the beam off because it's saying, hey, we're way out of tolerance here. We cannot be treating this patient because we could be treating a very close, healthy tissue that we shouldn't be. So we typically do these with left breast patients. We'll do them with lung cancer patients. I've actually seen a lot of them moving into treating anything in the GI region or even in the pelvis, just because they have it. So why not use this kind of this fine tuning skill that also can prevent additional exposure to healthy tissues. So a lot of people are going to using it all the time. So this is like our last thing that we'll do before we image our patient is we will do our motion management while they're on the table and fine tune anything that we can. And then even if we're a little bit out of tolerance, we'll say, okay, well, let's go ahead and image because maybe what we're seeing on the patient's skin for our marks lines up, but then this is telling us that maybe we aren't quite there. So then if we do our CT imaging or X-ray imaging, when it comes up, we can match and see exactly how far off we are. And then usually once we do that last final shift before we treat the patient, then everything's going to go back into being green. So we're good to go at that point. You can also do what we call a recapture. And so what it'll do is, let's say you get everything set up on the table and this is still red and your imaging looks good. Your doctor's happy with your picture saying you are spot on, but this thing is not right. You can recapture and it basically just resets itself to that moment in time saying, okay, this is actually what we want and we can reset it based on our physical proof of imaging. So it's not a, oh man, something's not lining up here. Your doctor can give you the approval to recapture if needed. Immobilization devices have to be stored somehow. And so typically we are looking at vac locks and masks, and then you may have like sponges, rubber bands, diving rings, bite blocks, a few different things. So when we store these, typically our vac locks are going to be hanging from like some type of cart or like a clothing rack, and they'll have a hook on them and you just hook them onto there and they'll hang. Or in order to preserve patient personal information, typically when we label our backlocks, we'll put a piece of tape on there and we'll write their name on the tape because we can reuse these backlocks. So we'll just rip the tape off when we're done and sanitize and reuse it. But in order to protect their personal information, we typically will put the bags so that the names are facing the wall. So that way, when more patients come in to be treated, they don't see the other patients' names that are being treated. Inside of the cabinets, again, we will have names on them. So you can kind of see, like right here is a name, here's a name, here's a name, here's a name, here's a name. And so within a cabinet, people shouldn't be going through these, so it kind of doesn't really matter which direction they face. But you want to make sure that every single one is labeled, so that way when you go to grab it for the next patient, you know whose masks is whose. And then if you have like your bite blocks with any of these, you usually will put them in like a sealed like container of some sort and put it next to your mask so you don't lose it. Um, so they have this, and then they have some of the longer or larger ones that maybe don't fit in a cabinet. They also hung these from a clothing rack. So if you have any extra table attachments that you might need, those are usually kind of stored either within a cabinet or kind of leaned up against a wall. If you need a swimming or a diving ring, those are usually kept kind of just in a miscellaneous spot. Foam blocks for in between their feet. If you have tongue depressors for any reason, or rubber bands, again, they'll kind of have their own miscellaneous spot. We may also need additional storage for locations for gowns if we have to change the patient, blankets, especially if they're cold. Some places will have the warm blanket machine. And then also you're going to need sheets or pillowcases to help cover patients when you expose them. And then any kind of quality assurance and linear accelerator equipment that's needed for that quality assurance. So, like I mentioned, that daily QA machine that we use, if the physicists have any bigger objects they need for phantoms, all those things, they need a place to be stored. So usually there's a fair amount of storage inside these rooms. As I mentioned before, your changing location is going to look different for every facility. So some places have the space in order to create true changing rooms for the patients, or they may have like a larger area with cut off kind of curtains or dividers. Where I did my clinical location, we just had like a corner that was within the treatment linear accelerator room, and so we had curtain dividers over there, and so we could just send the patient on in. They knew where to go. And then we could see on the camera once they got to the table. We didn't have cameras in that changing location. We had no capability of seeing right there. It was just once they started walking up towards the table, we could see once they got within like a 4 foot distance of the table. So that would tell us, oh, they're done. Or sometimes they'll holler out and say that they were, but that would allow them a privacy place to change, and they knew people weren't going to walk in on them. Our control area is going to be outside of our treatment room, and it's going to house all the monitors and information, things that we need to control our linear accelerator. So it could actually be a large room and house multiple machines, uh, meaning that if you have three linear accelerators, you may have three different stations within the same room, all operating those machines. So you could have a lot of therapists. Typically, it's recommended to have at least two therapists per machine. So you could have 6 people standing in that room operating the linear accelerators. You're going to have multiple monitors. There's kind of a lot going on. We're not nearly as bad as the radiologists with all of their stuff, but we will have quite a few things. We have audiovisual controls so that we can see and hear our patients. We will have our motion management monitor so we can see as a patient moves or if they move out of threshold. And then we have extra computers for charting and to make sure we have the patient's future appointment set up, anything they might need, access to the web, because we sometimes have to log into other systems and things like that. So on this bigger image here, you can see this monitor has our treatment plan. You can see the patient on here. Over here is where all the individual beams would be for the patient. And then on this side, we have our MLCs, so you can actually watch as they change. Over on the right-hand side, then, we're going to see that is our imaging area. So after they've done a CBCT for this patient, and they can go ahead and align that to the previous images and make any shifts based on the imaging component. Then up here, we have our motion management monitor. So with this patient, they're going to be monitoring and seeing how they breathe or they move to make sure that they're within threshold. And this one is, in fact, not in tolerance. So these are all out of tolerance. And so therefore, they cannot beam on right now because it is outside of what they are allowed to do. And then down here we have our audio visual monitors, which this is a bit excessive for one machine. Typically you have 2 monitors and then you have the one that's up on your screen, which works just fine. But these ones apparently they like those audio visual monitors. And so here's another setup version of how they might do that. They have their audio visual down here at the bottom. They have their monitor with all of the beams. They have their imaging on the right-hand side. This is probably where they do their motion management when it's necessary. And then over here is going to be where they have the separate computer to chart their information.